Okay, perfect. I think I can take over here. Yeah, so my name's Radhika Ratnabala-Suryar, and I'm one of the medical epidemiologists over at CDPHE, and I'll be talking today about antimicrobial resistance. So some of our objectives are listed here for today, some basic principles of drug resistance, including epidemiology, causes of resistance, clinical manifestations, diagnosis, and prevention. And then we will talk a bit about Candida auris compared to other Candida species, and in particular, go over some of its properties of drug resistance. And then we will finally cover some prevention strategies to help reduce the risk of transmitting or acquiring infection with Candida auris. Next slide, please. So to start with, we're going to cover basic principles of antimicrobial resistance. Next slide, please. So first, it's important to understand how our infections spread. And so an infection occurs when germs enter the body, increase in number, and cause a reaction. And really, three things are going to be necessary for an infection to occur. You need a source. So this is going to be a place where infectious agents, so germs, live in surfaces or sinks or human skin. And then you need a susceptible person. So this is a person with a way for germs to enter the body. And the last part of this is transmission. So we have to have a way that germs move to that susceptible person. Next slide, please. So what kind of microorganisms can make you sick? So the first one, and one that you might be familiar with, are viruses. So we've heard a lot about COVID, for instance. And a virus contains a segment of nucleic acids. So this can be RNA or DNA and a protein code. It cannot copy and spread by itself. It must infect cells in a host, so let's say a human host, in order to make copies of itself. Next slide. When we compare this to bacteria, these are instead small single-celled organisms. And there can be good bacteria, there can be bad bacteria, which we then call pathogenic, in our bodies. And most of bacteria that's in the body is harmless, but some species of bacteria can cause disease. Next slide, please. Fungus is the last group here that I'll talk about, and that can be a single-celled or multicellular organism. It's a very small number of fungi that can cause disease in humans. Next slide, please. So then what is antimicrobial resistance? The definition of antimicrobial resistance is when microorganisms, so whether we're talking about bacteria, viruses, or fungi, they change over time so that treatments that have worked well in the past are no longer effective. And we worry about this because it can spread disease, it can cause severe illness, and it can even cause death. Over time, infections from drug-resistant organisms become difficult or maybe even impossible to treat. And so antimicrobial resistance can also result in increased costs due to prolonged hospital stays and what could be really complicated treatment courses. Next slide, please. So why does resistance happen then? So here I'm going to show you a case of antibiotic resistance, but really these concepts can go across to other microbials, so bacteria, virus, fungi, parasites. And some of the reasons that this happens is overprescribing of medications, patients not fully completing their treatment course. It could be from overuse of, let's say, antibiotics in livestock and fish farming. It could be because of poor infectious control in hospitals and clinics. It could be from a lack of hygiene and poor sanitation, and also because there's a lack of new medications being developed to replace the ones that are no longer working. Next slide, please. And so focusing on antibiotic resistance here, misuse and overuse of antibiotics have contributed to antibiotic resistance. And according to CDC, more than 2.8 million people in the US become infected with bacteria that are resistant to antibiotics. And at least 35,000 people die each year as a direct result of these types of infections. Studies show that 30 to 50% of prescribed antibiotics are unnecessary and not optimally prescribed. So that is part of why we're here today speaking on this topic. Next slide, please. So now that you have that background on antimicrobial resistance, we're going to talk about specific organisms. And to start, we'll go over Candida auris, which is an emerging resistant fungus. Next slide, please. So you may have seen headlines regarding Candida auris. It was first detected in Japan in 2009, but now it's worldwide, including in the US. And the first US cases were identified in 2016. And part of the reason it was in the headlines is because it was identified as a superbug. Next slide, please. And so the significance of Candida auris, and the reason that you saw this in the headlines, is because it's highly drug resistant. Patients can become colonized and develop invasive infections from this. And typically this infection is spread in healthcare settings. Next slide, please. So why are Candida auris cases increasing? Some reasons for this include poor general infection prevention and control practices in healthcare facilities, along with increased surveillance of both clinical and screening cases. And overall, that is why we're seeing some increased number of the cases of Candida auris. Next slide, please. But I do want to point out here that Candida auris is not a threat to the general population. So although you're seeing this in the headlines, it's important to remember that this typically affects the sickest of the sick. So this is an infection that we see in hospitalized patients or at ventilated skilled nursing facilities. Next slide, please. People who get C. auris infections usually have a lot of comorbidities, and some of these comorbidities are listed here. So maybe the person has a tracheostomy. This is a surgically created hole in the windpipe that allows for breathing. They may be ventilator dependent. They may have a feeding tube or neurologic diseases, cardiovascular diseases, or poorly controlled diabetes. They may be colonized with other multi-drug resistant organisms, or they could have recently received antibacterials and antifungals. And then the last point here is we do think of this diagnosis when someone has received healthcare abroad within the last year. All right, next slide, please. And so is there treatment for C. auris? There are 3 classes of antifungals, and there's been 2 unrelated pan-resistant cases found in 2019. So although there are treatment options, there is resistance. And so this is a concerning finding, and the reason that there's more research and studies being done on Candida auris. Next slide, please. What can we do to prevent C. auris in similar, or prevention of C. auris, is similar to other drug-resistant bugs. So we're going to go back to your basics here. This is really no different than other drug-resistant bugs as far as prevention strategies. So you're going to want to practice good hand hygiene, use your personal protective equipment and precautions, and of course, do environmental cleaning and disinfection. Next slide, please. So a knowledge check here is C. auris a threat to the general healthy population? And the answer here is false. It's not a threat to the general healthy population. Again, when you think about C. auris, really think about those patients who have comorbidities or some of those risk factors that we talked about specifically. They're ventilator dependent, They received healthcare abroad in the last year, or maybe they're specifically coming from a facility that had reported C. auris cases. Next slide, please. So we're going to switch gears a little bit here and talk about ringworm, which is another source of fungal resistance. Next slide, please. What is ringworm? Ringworm is also called tinea, and it's a common fungal infection of the hair, skin, or nails caused by dermatophyte fungi. Ringworm spreads easily by skin-to-skin contact with infected animals or people, and by fomites, which are everyday objects or surfaces that may be contaminated. Usually, ringworm skin infections are minor and can be treated successfully with topical antifungal medications or oral medications in cases of widespread infection. So this is a diagnosis, unlike Candida auris, that you may see quite commonly in your setting. Next slide, please. So dermatophyte infections are caused by fungus that infects the skin, hair, and nails. And you may know these as some more common terms like athlete's foot, jock itch. You can have fungi infection on the hair or scalp or along the body. Next slide, please. And so when we look at the epidemiology of ringworm, the incidence is up to 60% of all prison skin infections. And that's why I'm really saying to you that this is something that you're more likely to see than Candida auris. It is spread through direct contact and fomites. It does not infect the mucous membrane, so things like the mouth or the nose. And the reservoir is in humans, animals, or soil, but it's usually not life-threatening. Again, it can spread easily. Risk factors for this infection include moist skin, so sweat, immunocompromised status, so a weakened immune system, diabetes, or topical steroid use. Next slide, please. So drug-resistant ringworm infections are emerging, and that is why we're discussing this today. There were some severe antimicrobial resistant infections that were identified and found to be widespread in South Asia. But then in early 2023, dermatologists working with labs and CDC were able to identify the first 2 US cases of this. And these infections are emerging in the US and require advanced molecular methods to confirm cases. And so we wanted everyone to be aware that this is a possibility where you could come across these newer drug-resistant ringworm infections. Next slide, please. Here are some of the signs and symptoms of this infection. So some pictures of ringworm on the back, on the arm, or on the scalp. And you want to think of these rashes as itchy and not painful. Next slide, please. Prevention strategies here: changing socks and underwear daily, clothing with moisture wicking fabric, using drying foot powders, and not walking barefoot in gyms or shared showers. We also don't recommend sharing of towels or personal items, and treating shoes with antifungal powder can help. Prompt medical evaluation and treatment of those who have symptoms of fungal infection is recommended. I think that's everything for this slide. Next slide, please. So treatment of ringworm. Treatment depends on the location and seriousness of infection. So as mentioned, this is an infection that can be treated with over-the-counter medication or prescription medicine if needed. And really, we want you to think about contacting a healthcare provider if the infection worsens or doesn't go away after using non-prescription medications. And then specifically, ringworm on the scalp needs prescription medication. Next slide, please. Next, we're going to talk about dental infections. And we're talking about dental infections specifically as a source for bacterial resistance. Next slide, please. People who are incarcerated may have worse oral health. And this is compared to people who have never been incarcerated. Socioeconomic status and health behaviors may contribute to this difference. And literature specific to oral health in people who have been incarcerated is somewhat limited. Next slide, please. Poor oral health has far-reaching complications. So we may think to ourselves, not as big of a deal as other things we might see that need medical treatment. But I really hope I can change your thinking on that, because poor oral health can result in severe infections, and it can also affect other things. People tend to experience an immense amount of pain and discomfort, and they may also suffer social and economic consequences from poor dentition. The degree of oral health care during incarceration can vary, and this does make treatment challenging. And dental care and treatment often do not continue when the individual returns to the community. Next slide, please. Dental pain does have a variety of causes, one of which is dental caries, also known as cavities. This is caused by a breakdown of the tooth enamel by acids produced by bacteria located in plaque that collect on teeth. Eating and drinking foods high in carbohydrates cause this bacteria to produce the acids that can cause the outer coating of the tooth or the enamel or the root surface to break down. Next slide, please. Cavities are a common occurrence. Although cavities are largely preventable, they are one of the most common chronic diseases throughout the lifespan. About 1/4 of adults aged 20 to 64 have untreated cavities, and more than 90% of adults have had a cavity. And to the right here, I'm just showing you the stages of cavity formation here. And the first two stages are typically not painful. The last two stages are painful or very painful. Next slide, please. And so with cavities, untreated tooth decay can lead to abscesses, which are severe infections under the gum and can spread to other parts of the body and have serious and, in rare cases, fatal results. I'm showing here that stopping tobacco use is an important part of oral health. Untreated tooth decay is higher in people who smoke cigarettes. And among adults aged 20 to 64 years, over 40% who currently smoke cigarettes have untreated tooth decay. So here you can see the difference in the chart between current smokers, former smokers, and never smoked, and their rates of untreated tooth decay. Next slide, please. So moving on to gum or periodontal disease. Gum disease is mainly the result of infections and inflammation of the gums and bone that surround and support the teeth. Certain chronic conditions will put you at risk for this type of disease, and that includes diabetes, a weakened immune system, poor oral hygiene, heredity, and tobacco use. In early forms of periodontal diseases that are not treated, the bone that supports the teeth can actually be lost and the gums can become infected. Teeth with little bone support can become loose and may eventually have to be extracted. And one other thing to note here is that taking medications that cause dry mouth can also increase your risk of gum disease. And so dry mouth would then in part increase your risk of cavities and tooth decay. Next slide, please. So looking at the treatment of dental infections and some general principles here. Treatment is going to depend on the type of infection. So when we look at the acute phase, that's going to mean it's a quick onset over a few days, versus when we look at chronic, that's going to be more ongoing for several weeks or longer. Then we look at the degree and severity. Is this a localized infection or is it spreading? And the last thing we look at and consider is the ability of the patient to fight off different types of infections. Are they with a fully functioning immune system, or do they have a weakened immune response? And part of this is going to include what is their follow-up for dental care that is definitive. The best practice for management of dental infections is for a dentist to remove or drain the source of infection. And the source is commonly a necrotic or dead pulp of infection, or a deep dental pocket of infection. Next slide, please. So looking at the American Dental Association treatment guidelines, we can see here a few important notes. For pain control, it's important to consider over-the-counter pain medications. Narcotic pain medication is not typically recommended. Antibiotics are not routinely prescribed as an adjunct to most dental conditions when you have access to definitive conservative dental treatment. And antibiotics, in light of that, may be needed in certain situations, especially if there's systemic involvement. So it's spreading, involving more parts of the face or deeper tissues, or maybe you have somebody at risk for systemic symptoms. So maybe they do have that weakened immune response, or they're a poorly controlled diabetic. And so there's some nuance here with prescribing antibiotics, but wanted to show a general guideline for antibiotic recommendations. And when you are prescribing antibiotics, the typical regimen is amoxicillin or penicillin V. And if they have allergies to penicillins, there are other options that you can find at the ADA resources. Next slide, please. Antibiotic safety is for providers, but also for patients. And so we want patients to understand if they have any drug allergies or medical conditions so that we can make the best decision on the type of treatment needed. We also want to know about medications, vitamins, herbal supplements, so that we know if there's going to be any interaction with the medications we're giving. And we do want to be mindful of how far this has spread. Is this a localized infection, or does this look like it's involving more of the deep tissue or more of the face? And then we want to remind patients to take their antibiotics as prescribed. So many patients will come to me and say, but I was feeling better after the second day, so I just stopped taking it. And really, that's our job as providers to explain and educate the purpose of antibiotics and how they will work. That if they stop early, that they may only partially treat the infection and the infection can return. And so even if you're feeling better, it's really important to complete that full course of antibiotics. And then we want to know if they experience any side effects, such as diarrhea after taking the antibiotic or shortly after stopping the antibiotic. Some antibiotic choices can result in C. diff colitis, which is an infection of the gut. And that's something we do have to take seriously and monitor for. And if a person were to have that complication, they would need to seek medical evaluation. Some things we don't want patients to do when prescribing antibiotics for this: we don't want them, again, to skip doses or stop taking them because they feel better sooner than the treatment course ends. We don't want them to save any unused antibiotic for future use or give their antibiotics to other people. I can't tell you how many times I've run into this. So it definitely happens, and we just want to remind people why we don't want them to do that. It's not that we're trying to make it inconvenient for them. It's really that it's unsafe, and it can cause and add to the problem of antimicrobial resistance. But also we want to make sure that it's safe for another person to even take those antibiotics. They have a different medical history, may have different allergies, may have different medications that interact. Let's see here. The other thing we would like to remind people is to not pressure providers to prescribe an antibiotic. If you're a provider, I'm sure you've been in this situation before, and We encourage people to ask whether they think antibiotics are appropriate. And on the provider side, it really is our job to explain sometimes why we aren't doing something. Just as much as it's important to explain why you're doing something, you have to explain why antibiotics are not indicated. And things like saying, at this point, it doesn't appear that you would meet the criteria for antibiotics. Instead, here is your treatment plan. We're going to give you over-the-counter pain medication. We're going to get you set up with a dentist to address this particular illness of your dental cavity. And if things are looking worse, if we think this infection is spreading, then we would consider antibiotics at that time. So those conversations, again, really important to have between provider and patient. Next slide, please. So a knowledge check here, a 36-year-old incarcerated male is transferred to your jail from a different facility. And upon admission, he states that he has an ongoing toothache for the past 2 months and noticed some gum swelling near the painful tooth for the past few weeks. He received 2 different courses of antibiotics at his previous correctional facility without resolution of his symptoms. And so what would be the next best steps? And I'll tell you, this is a scenario that I've seen plenty of times. I've seen patients come on their 3rd, maybe 4th course of antibiotics. And so the answer here is not to just prescribe the same antibiotic for a longer treatment course. The answer is not to prescribe just a different antibiotic without any other plan. It really is to refer the patient for dental evaluation by a clinician and ideally a dentist. And they can decide, does this person need any further antibiotics? And more importantly, they can treat the underlying cause, because for much of this, you can give antibiotics, but until we treat the underlying reason, the infection can come back over and over again once they've completed the antibiotic course. All right, next slide, please. So we're going to talk now about gonorrhea infections, which is another source of bacterial resistance. Next slide, please. So it's important to remember that gonorrhea often has no symptoms at all. It is a sexually transmitted disease that can cause infection in the genitals, rectum, and throat. It is very common, especially among young people ages 15 to 24 years. It is spread through vaginal, anal, or oral sex with somebody who has gonorrhea. And a pregnant person with gonorrhea can give the infection to their baby during childbirth. As mentioned, gonorrhea often has no symptoms, but it can cause serious health problems, even without symptoms. Next slide, please. Gonorrhea cases are increasing in the US. So I'm showing here the rates of men and women, and then the total rates. It is the second most commonly reported bacterial infection in the United States, with 1.6 million new infections annually. And about half of those gonorrhea infections are resistant to at least one antibiotic. Next slide, please. Cases in Colorado have increased since 2012. So this is not just a national problem, it is a problem in Colorado. And here I'm just showing you that difference with the coloring here from 2012 to 2021. You can see Colorado is now at a rate of the range 199 to 658. Next slide, please. Untreated gonorrhea can cause serious problems. In women, untreated gonorrhea can cause pelvic inflammatory disease, which is also known as PID. And some of the complications of PID are formation of scar tissue that blocks the fallopian tubes. It can cause a condition called ectopic pregnancy. So this is a life-threatening condition. Potentially, it's when the pregnancy is in the wrong location outside of the womb. It can result in infertility, so not being able to get pregnant. and it can result in long-term pelvic and abdominal pain. So these are really severe complications that we really want to prevent. In men, gonorrhea can cause a painful condition in the tubes attached to the testicles, which is called epididymitis. And in rare cases, this condition can lead to infertility. Rarely, untreated gonorrhea can also spread to the blood or joints, and this is then called disseminated gonococcal infection. And this condition can be life-threatening. Untreated gonorrhea may also increase the chances of getting or giving HIV. Next slide, please. So treatment of gonorrhea is typically with an antibiotic injection. CDC recommends a single dose of 500 milligrams of intramuscular ceftriaxone, which is also known as Rocephin. Alternative regimens are available when ceftriaxone cannot be used to treat urogenital or rectal gonorrhea. People with pharyngeal or throat gonorrhea, regardless of presence of symptoms, should receive a test of cure, so repeat testing after completion of therapy, 7 to 14 days after initial treatment. And for uncomplicated urogenital gonorrhea, patients should be retested if symptoms persist. Next slide, please. Here we're going to show you the evolution of gonorrhea resistance to antimicrobials. The color changes you're seeing here indicate events that impacted the level of resistance along the time each antimicrobial was used. So currently only ceftriaxone is recommended as first-line therapy, and doses have been doubled since the drug was first used. Next slide, please. Prevention is really key here. So abstinence and/or celibacy are the only ways to completely avoid STIs, HIV, and viral hepatitis. But those options may not work for some. And we know abstinence does not work for everyone. So for those who do have sex, there are other ways to prevent STIs, HIV, and viral hepatitis. We recommend you talk with your partners and have open conversations about sex and other risk factors like injection drug use. We recommend condoms and dental dams as an effective way to prevent the transmission of HIV and STIs that are passed through body fluids. Using lube can also help reduce the risk of creating small tears in the skin that could increase your chances of coming into contact with STIs. If you inject drugs, do not share or reuse needles, syringes, or other equipment. And we recommend getting vaccinated, taking medications as prescribed, and talking to your doctor about PrEP and PEP for HIV prevention, or HAART if you have HIV. Next slide, please. So preventing antimicrobial resistance, what can we do? Next slide. So as healthcare providers, what can we do? Preventing infections can happen by ensuring your hands, instruments, and environment are clean. We also want to make sure that we only prescribe and dispense antimicrobial treatment when it's needed and according to the current guidelines. We should report antimicrobial resistant infections to surveillance teams so that we understand trends that are happening and can act early. We recommend talking with your patients about how to take medications correctly, antimicrobial resistance, and the dangers of misusing medications. And then we want you to talk with patients about prevention. So whether that's through vaccination, hand washing, safer sex practices, and covering your nose and mouth when sneezing. Next slide, please. What can individuals do? Individuals can only use medications when prescribed by a certified health professional. And we also want people to be mindful and not demand antibiotics or antimicrobials if your healthcare provider says you don't need them. Always follow your healthcare provider's advice when using antimicrobials or antibiotics. And that means completing the full treatment course, not skipping doses, and not sharing your medication with other people. And then we want to, again, prevent infections by regularly washing hands, preparing food hygienically, avoiding close contact with sick people, practicing safer sex, and keeping vaccinations up to date. I think with that, that's everything today. Next slide and next slide. Yeah, perfect. So thank you for having me. We are happy to take any questions that you may have. And thanks for joining. I hope this was helpful.
Thank you, Dr. Ratnabala-Suriyar, for that very informative presentation. If attendees have any questions, you can put them in the chat or use the raise hand feature or unmute yourself if you're able to do that. I'm going to look at the chat right now. Oops. And in the chat, we've also put the link to CSOC's YouTube channel. That is where this presentation recording will be posted, and that is where all of the past training sessions are also posted, so you can view them there. And then also in the chat is the training evaluation survey. We ask that you please complete this training, whether you're watching it live, complete the survey, whether you're watching the training live or whether you are listening to this as a recording. If you're listening to a recording, the survey is linked in the description of each YouTube video on CSOC's YouTube channel. So if you complete that, that helps us improve future sessions and gives us ideas for future trainings. I'm not seeing any questions in the chat right now, and I don't think anybody has their hand raised. So again, thank you to our presenter and thank you to CSOC for partnering with us at CDPHE to host this training. And we hope you all have a great afternoon. Thank you.